Annunziato.
Thank you. Good evening, everybody. Thanks for honoring me with your time. I really appreciate it. Hopefully, you find this lecture engaging and entertaining. And if there are questions, think about them, and then hopefully we can address them at the end of the lecture, I'm sure. So, a little bit about myself. So I'm a Jersey guy. I grew up in Manalapan, New Jersey, which is Monmouth County. I did a undergraduate at Providence College in Rhode Island, came back to New Jersey for medical school. I went to South Jersey, did my internship in Philadelphia, came back up. Now I'm in North Jersey, did my residency, again, as Perminder said, through Rutgers, New Jersey Medical School, the Kessler Institute, the VA, and Children's Specialized Hospital. So a lot of different variety of settings, a lot of different kinds of patients. And then I did something pretty unique, an osteopathic neuromusculoskeletal medicine fellowship. There's not too many of those in the country. There's only about 20 or so programs. And I, as a physiatrist, and to my knowledge, I'm the only physiatrist in New Jersey who then did an ONMM fellowship. And so I'm kind of one of one, at least in this area. So my job tonight is to highlight the osteopathic difference, to explain how a physical medicine and rehab or PM&R physician can help with both injury prevention and recovery, and explain how osteopathic manipulative treatment, or OMT, fits within a whole person approach to health. Cool. So I think the first thing that we need to address is, what is DO? What are those letters? What do they mean? So DOs are doctors of osteopathic medicine. Many people, you think of a physician, you hear, oh, my doc's an MD, or what's a DO? You may not notice it. So the first thing is like, oh, what are we? What do we do? So we're fully licensed physicians. We cover all medical specialties: family medicine, internal medicine, peds, rheumatology, OBGYN, surgical specialties, ENT. We cover the gamut. Very similar to our MD colleagues, we do 4 years of medical school. We do internships, we do residencies, we do fellowships, we sit for board certification, multiple board certifications. So very similar to our MD colleagues. You may not realize that you're seeing a DO for any of your subspecialties, much like a dentist could be a DDS or a DMD. So I get asked all the time, so what's the difference between you, a DO, and an MD? And realistically, there's not a whole lot that you might pick up on, but it's the training and the focus that really set us apart, and maybe something that you might look for in your care. So basically, DOs get additional training in medical school in the musculoskeletal system, and we focus on injury prevention and whole health. So we learn everything from how to read x-rays, how to perform different techniques, procedures, surgical stuff, but we learn a special kind of tool called osteopathic manipulative treatment that help improve the patient's function. And there's a great quote that I really enjoy. It basically says, osteopathic physicians focus on prevention, tuning into how a patient's lifestyle and environment can impact their well-being. DOs strive to help their patients be truly healthy in mind, body, and spirit, and not just free of symptoms. And that's something I really kind of take to heart. All right. So about OMT, the brunt of this topic. So osteopathic manipulative treatment, or OMT, is a set of therapeutic techniques that us DOs use, and it's for both diagnosis and treatment. And the goal is to prevent illness or injury. It is a manual therapy, and a DO will move a patient's muscles and joints in a variety of styles. Some are gentle stretches, some are a little bit of pressure, some will have you push against resistance, and the goal is to promote better function. OMT can help a variety of patients in all ages and all backgrounds to complement a whole body approach to care. And, the goal is using this as a tool for a patient's health. And oftentimes patients come with their goals, and the goal may be, I don't want another medication, or I really am not looking forward to surgery. I want to kind of delay that. Can you help? And OMT is another tool in the toolbox, and that we can find very helpful. All right. Then my specialty itself, physical medicine and rehab, which is also known as physiatry, which is also known as PM&R. It's also known as the specialty that no one can pronounce because it's so many letters and we don't own any joint. Basically, PM&R physicians, we're function doctors. So I don't own the heart like a cardiologist. I don't own the lungs like a pulmonologist. I own the whole body. I tend to see patients that have a variety of musculoskeletal conditions or nervous system conditions. So conditions that affect the brain, the spinal cord, the nerves, then bones, joints, ligaments, muscles, and tendons. I often get a lot of like, are you sports medicine? And yes, I see a lot of sports medicine. I also see a lot of people who have injuries and disabilities. And I say, yes, I see that too. So I share a lot of patients with neurology and rheumatology and neurosurgery. And basically, our goal is to work on people's function, and we provide kind of a second set of eyes. And maybe we're not chasing numbers, but we try to focus on the whole patient. PM&R basically focuses on quality of life, and we have a lot of tools in our toolbox. So there's therapeutic exercise, things to help you get stronger, maybe promote your endurance, flexibility. I write for medications all the time when it's appropriate and patients interested. I am kind of a master in different modalities. When do you use manual therapy like OMT? When do you use heat? When do you use ice? Is ultrasound appropriate? Is a TENS unit appropriate? Hot baths, different stuff like that. I help patients focus on their mobility. Should they be using a walker? Should they be using a rolling walker? Should they use a cane with 1 point? Should they use a cane with 4 points? Self-care training. Not to get gross, but as we get older, sometimes it's difficult to use the bathroom and clean up after ourselves. Who's the doctor that helps you when you can't wipe? That's me. I do that. So I handle the weird. I handle the functional tasks that become challenging and no one wants to talk about. I prescribe adaptive equipment, assistive devices, braces. If you lost your leg and needed an amputee, and who manages the splint, the prosthetic leg? Me. If you have a foot drop, who manages your brace? Me. If you can't walk anymore and you need a wheelchair, who writes for the right chair that has the right tilt and space, the soft cushion, the back that fits? That's me. And then I also do a lot of different procedures. I do a lot of spine and joint injections, and PM&R does them under fluoroscopic or X-ray guidance or ultrasound guidance. So to add a meme, you have DOs and you have physiatrists or PM&R doctors, and our whole focus, both specialties from the jump, is improving your whole health from mind, body, and spirit. So who are my patients? This is not an exhaustive list, but this is a lot of what I see in a given day or a given week. So I see headaches and migraines, see a lot of TMJ pain. So I share that with neurologists. Neck and back pain are my bread and butter. We see a lot of that, especially if you have a degenerative or herniated discs. Women's health. I see a lot of pelvic floor pain and a lot of SI joint pain that just hasn't responded well. And I take a nice, I would say about 10 to 15% of my patients are pregnant women because they really can't have anything but Tylenol, and we have to manage their back pain during pregnancy. And then you pick a joint, I take care of it. Tennis elbow, golfer's elbow, frozen shoulder, carpal tunnel, knee pain, foot pain, plantar fasciitis, different types of injuries like stroke or a spinal cord or cancer, and then different types of pains like pain associated with anxiety or depression, or cancer-related pain or stuff like that. So I'm going to spend a little bit of time providing some examples of real patients that I've had and how I've utilized OMT to improve their overall health. And I think you'll be able to get an idea of what, as a physiatrist, I do and how I utilize OMT to really, impact the quality of life of the patient. So, all right, working from home. This is pretty common right now. So Maggie is a 40-year-old mother of 3. She's working from home because of the pandemic. She's got pain across her neck and shoulders. She notices that when she's stressed out, oh, it really feels bad. And she's got this 3-year-old, sweet little 3-year-old girl. And when she lifts her, tight, tight, tight. She tries to do the right thing. She stretches, she exercises. She's been skipping out at the gym because, she's a little not safe. Like, she doesn't feel comfortable. But she's otherwise pretty healthy. So we do a whole history and physical in the office. And after that, what did we do for her? So we reviewed the ergonomics of her work from home setup. How do you sit properly? Many of you, I can just kind of tell right now, are adjusting how you sit in your chairs to watch this, are adjusting your seat height, adjusting your monitor. Is your keyboard in the right place so that your shoulders are not all the way forward? We talked about different topical creams because oral medications upset her stomach. And so she's like, no oral pills. Cool. She's a full-time mom. She has a full-time job. It's very tough to go to physical therapy. So I wanted to make sure that she has a home exercise program that would work for her. And then we tried OMT because she wanted to try this before jumping to an injection. So this is a picture of me in a simulated patient doing something called a suboccipital release, where I'm applying a gentle pressure just under the head, right into those tight trapezius muscles. And the goal is to kind of stretch the muscle, increase the motion, promote compliance of the muscle, and encourage good circulation so that, like, the tight muscles around the neck soften up. Okay. Next case. So Kelvin is 57 years old. Kelvin's a character. He works full-time in a restaurant. He does a little bit of everything. Like, he's a cook, he's a busboy, he hosts, he's busy, he's grinding. In addition to kind of running that restaurant more or less, he does his mother's landscaping for her home. And this was written in the fall, but basically he overdid it over a weekend. He raked all the leaves, and it was kind of tight. His back pain is something that has always been there, and he's lived with it. It comes, it goes. He takes some Advil, he takes some leave, dials back the exercising for a little bit. It gets a little bit better. He goes back to work, maybe tries a brace, stuff like that. But at this time was a little different. He's like, I'm getting a lot of tingling in my foot. I know I have diabetes. Is it diabetes? Is it sciatica? I get this question all the time. So we did a whole history and physical. He brought in old x-rays. That was great. We reviewed them together, showed the arthritis that he has. Because he brought him in, we didn't need to repeat those films. Now, we did take a look at his most recent hemoglobin A1C. For those of you who don't know, the hemoglobin A1C is the marker that we check for diabetics every 3 months to see how you're doing with your diabetes. He has a Valley primary care doctor. Because I'm a Valley doctor, we share the same network. I fired off a message to his PCP. I said, hey, listen, he's got numbness in his toes. His A1C was high. This might be more diabetes. We talked about bracing. And in addition to talking about bracing when he does yard work, because you don't want to over brace, I looked at his feet on exam, and he made sure that we were in the proper footwork, because I just happened to see that he had flat feet. Because he's diabetic, you can't give steroids. Steroids will elevate a person's blood sugar. So I prescribed a muscle relaxant. And he was able to go to physical therapy, and our focus was on core strengthening. I also provided him or performed some OMT because I thought that would help some of the guarding that he has, so it allowed him to relax and sleep. And then I also laid out the plan in case the things don't work. So it's like, all right, next step, MRI, maybe an injection, but we have to see how you do with the conservative stuff first. So for Kelvin, we did this technique. So it's called gluteus muscle energy. Basically, I am stretching the gluteus, and the patient pushes against my resistance. I have taken them to the barrier, and after they push me, you get this relative relaxation. And basically how this technique works is there's something called the Golgi tendon reflex, which is a very, 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 very tiny thing within some of our cells that allow us to basically say, hey, fire or don't fire for your muscles. if you've ever gone to a sporting event back when we used to be able to go to sporting events and hey, now we can do that again. And you ever see the trainer kind of stretch an athlete out, they engage the barrier and the trainer stretches them further. Similar technique. That's a common technique that I use in the office. All right, one more case. So Rose is 80 years old, and she is very focused on not becoming a burden on her children. So she had a long-standing relationship with an orthopedic surgeon. She's had her knees replaced, but she is a little older now, and she has AFib, and she can't really get off blood thinners. So that's a poor candidate for shoulder surgery. She has a lot of difficulty reaching with things over her head, so she tends to leave a lot of like clean things on her counter because she doesn't want to put them overhead. She's dropped a couple plates, happens, and we're handling kind of this family drama because she doesn't want to be a burden. The kitchen looks sloppy. Kitchen looks like this kitchen, where it's like everything is clean, but everything's on top of each other. And realistically, she's embarrassed, but she doesn't want to feel like her children are like, yeah, you probably need a little more help, Mom. And she's like, I don't want more help. So it's a tough case because it's more than just her pains. It's a lot of like, how do we handle the family? So again, took a history, did my physical exam, went over her shoulder MRI, and I wanted to explain to her and help her understand why reaching overhead is tough. We put her in occupational therapy at Valley to kind of help her learn how to perform her activities of daily living as pain-free as possible. We talked about tools, like in the picture here, a grabber, which will allow you to get the things overhead without actually having to reach up overhead. I did perform some OMT to loosen the shoulder because, again, she's on this blood thinner for atrial fibrillation. It gives her a higher risk with her procedure. And then we had a conversation with her family members, partly because we want them to know, but we want them to understand Rose's goals and the steps that she's taking towards her goals. That kind of diffused the family situation of, hey, Mom, maybe you should move in with us, or maybe we should get some help. Like, this is what we're doing. Let's see if this works. So for Rose, I did this technique called counter strain. Counter strain is a very gentle soft tissue technique where I basically place a tight muscle in a position of maximal ease. And then we get one side to relax, we get the counter side to relax. And once the competing muscles relax, meaning like bicep and tricep, how they fight against each other, if you can get them both in a position where they are both calm and able to be passively stretched, then you can mobilize the whole arm into the position of original comfort. Okay. So with that being said, let's go over some things. So DOs, or osteopathic physicians, we focus on whole health, mind, body, spirit. Physiatrists, or PM&R doctors, or function doctors. And we have a lot of strategies and tools with a goal of promoting pain-free quality of life and making sure that your plan matches your needs and your preferences. And that OMT is part of this whole health approach to patient care that promotes improvement in pain and function. And the goal is to try to not add additional medications or injections if they're not necessary. So with that, I'd like to open it up to any questions.
Thank you, Dr. Annunziato. We do have a few questions that have come in. If anybody else has any questions at home, please feel free to start sending them in, and we'll start going through the questions. So question number one, how does an osteopathic doctor differ from a naturopathic doctor?
Gotcha. Okay. So first things first, there are two types of physicians. So there's MDs and DOs. A naturopathic doctor is not a physician. A naturopathic doctor doesn't go to a medical school, they go to a naturopathic. So they call themselves naturopathic MDs. And it's a little misleading because it's not like they're doing internships and residencies. Um, they kind of specialize using different herbs and stuff. Um, and so while they, claim that they are managing the whole body and treating holistically, and I'm sure that they are, there's a difference in our training very fundamentally, that, just includes for your knowledge, we have to do 4 years of medical school. We have to then do an internship, a residency. There are board certifications for different specialties. That doesn't happen for naturopaths.
Great, thank you. So here's another question. Do you feel that you can be helpful to someone who has vulvodynia?
Sorry, what was that word?
Vulvodynia?
Vulvodynia. Okay, yes. So I have like 3 or 4 patients right now with vulvodynia. So vulvodynia, or pain around the genital area. I do see a handful of patients with pelvic pain, and usually I try to manage this with a combination of different things. Number one, OMT, and we work a lot on the lumbo-pelvic junction. Number two, Valley has some phenomenal pelvic floor physical therapists that I work hand in hand with. There are some localized creams and stuff that we utilize that can be tried. And very, very, very rarely there are injections for that. But generally, I've found that a combination of manual therapy and pelvic floor PT usually gets the job done.
Great, thank you. Another question. How do you generally treat knee pain? How do you determine the cause, and what are the common forms of treatment?
Sure. Okay. So knee pain could be a 4 to 6 hour lecture in itself, but it starts with the history. What were the circumstances regarding your knee pain? It also depends on age. Younger people tend to get strains and sprains. Older people tend to have more arthritic related changes. My physical exam differentiates a lot of things. So I try to test the patellofemoral tracking. I try to test how we load the meniscus to see if there's any meniscal involvement. I check for laxity to see if there's a ligamentous injury. And then, simple things like watching your walk and check your range of motion. And basically, after I do that, I try to steer your treatment plan towards where I think the cause of your pain is. Sometimes that's bracing. Sometimes that's a steroid injection or a gel shot of viscosupplementation. It may require the fact that you may be loading part of your knee because your glutes are weak and you're tracking a lot of your patella off because there's a muscle imbalance. So physical therapy can be helpful. Making sure we're in the right footwear. If your stride is thrown off and you're messing up your knee because your foot doesn't land properly on the floor, that could be a big thing. So that's a very broad way of framing the question. It's really person dependent. So, if you're having questions about your own knee, please feel free to call me, make an appointment. We will try to tease out some of this stuff. And absolutely, there's a role for X-rays and diagnostic imaging and MRIs and stuff like that. But, everything starts with a history and a physical exam, always.
Great, we're getting some more questions in. So the next question, can a physiatrist be a primary care doctor?
No. Short answer is no. So we tend to handle the niche related functional aspects, but I don't do things like titrate your blood pressure medications, your diabetes medications, things like that. I usually work hand in hand with a primary care doctor.
Great. What is the TENS treatment?
Sure. So a TENS unit, TENS stands for basically an electrical stimulation unit. So it involves patient putting on sticky pads, very similar to the leads of an EKG. And you put it over an area of sore muscles and stuff. And the unit, it's usually battery powered, sends a little electric pulse and the pulses, depending upon the type of unit you have, can be very customizable, stronger pulses, softer pulses. And the thought is that by stimulating the muscles with these electric currents, the muscles actually relax, and it can be useful for pain.
Thank you. Okay, this person is referring back to, I think, your first case, your case number 1 that you kind of went over.
Mhm.
And they're asking, I'm similar to case 1, except my cervical trapezius pain is chronic for 20 years due to scoliosis and structural spine issues,
Mhm.
not work from home alignment. I've done acupuncture, PT, foam rolling, exercise, etc. How long does a physiatrist treat you for this type of chronic musculoskeletal issue? Or do you just try one of these modalities in the office and prescribe follow-up from another type of doctor?
Yeah. So to answer that first part, I don't do any of these modalities in the office. So unlike a chiropractor or maybe some of the other providers, like there's no TENS unit here, there's no acupuncture here. These are here. My hands are here. So I'm willing to definitely try. Part of any evaluation that I do involves getting an understanding of what you've had before. So today, so I had a patient similar. She's had acupuncture, medical marijuana. She's had a cervical fusion, and we're still not out of the woods. Uh, so a lot of, if you've ever come to my office, maybe I can show on the board. Uh, if you can see the board in the background, there's different categories on the board, and we kind of cross off or add to a particular type of style. So if it's very faint, if you don't know if you can see it, but like the top left, that's kind of cut in half, is diagnostics, then it's procedures, then it's meds, then it's braces, and on the right-hand column, it's therapy, modalities, and consultations. So we try to figure out what's right for you, and we don't fill everything on that board. We may only use 2 of those things, 3 of those things. But basically, you're not the only patient I have with scoliosis and chronic neck pain. I definitely see a lot of that. And if you're interested, please don't hesitate to make an appointment, and we will see how we can best come up with a plan for you.
Thank you. What are the differences between your services and those of a chiropractor?
Yeah, okay, get that a lot. So, back to the training. Again, I'm a physician, and chiropractors kind of just go through chiropractic school. So they're not technically physicians. There's no internships, there's no residency, there's no fellowships. We're both trained in manual therapies, and a lot of our manual therapies are similar. The first chiropractor, about in the late 1800s, was actually a DO, and there was actually an offshoot of how our training styles were from. So the very first chiropractor was a student of one of the first osteopaths. Basically, osteopathic physicians kind of preserve their actions as physicians and learn medicines and surgeries and stuff in addition to the manual stuff. And then the chiropractors kind of schismed off and focused on that stuff. So there are some techniques that are very similar, your adjustments, your cracks. But I'll tell you that I don't do anything. I don't use a table to do any of my maneuvers. Everything is done with my hands. There's no like traction units. We don't put TENS units or stim on anybody, because a lot of how we're trained to diagnose and to treat with our hands. And so it's just a different style. Also, similarly, I may see a patient once and then not see them for a month. There's nothing in my training that tells me that I need to see a patient multiple times a week for 4 to 6 weeks. It's once, maybe twice in a month. And I'm usually giving you some sort of homework assignment, be it an exercise or I'm putting you in physical therapy, because from a philosophical perspective, I believe that if I put the body in the right place and give you the tools to preserve it, you will no longer need me. And that's kind of a goal of mine.
Great. Can you help with scoliosis and one leg shorter than another? than the other?
Sure. So I have a couple of people with short legs, and I try to manage them with uh, various like shoe inserts, heel inserts. And the goal is to basically align the pelvis. And once I get the pelvis aligned, that's a good goal. Generally, scoliosis in adults is something that you mitigate, but you don't correct. So I don't put anybody back who's had like a 15-degree curve and now suddenly you don't have a curve. My goal is to give you exercises so that one, the curve doesn't worsen, and two, that you can tolerate the pain. And that's kind of how I approach it. So I don't promise to fix you. I promise to allow you to have a better quality of life, assuming that the exercises and the shoe inserts or the heel lifts that I provide can help you get there.
So the person who just asked that question just wanted to clarify. So they write, to clarify, I cannot go up the stairs with both legs stepping up, and I would love to be able to go up with both legs.
Mm. It's definitely a challenge. I'd have to evaluate you to get a better understanding. It's hard to do that without seeing you and seeing how you walk. But usually that would involve some degree of strength training with a physical therapist, and in addition to all of the things that I mentioned before about, how are we managing your pain, and also, based on age, making sure like things like knee arthritis isn't an issue and stuff like that.
Okay. Do you have any advice for using smartphones as the user is always looking down and is hunched over, and that tends to exacerbate neck and shoulder pain?
Yeah. So there's something called upper cross syndrome. Upper cross syndrome is not actually a syndrome, but it is kind of what you describe, where you're looking down, your shoulders are tight. A lot of it has to do with two different things. We need to stretch our chest wall open, and we need to focus on pulling our shoulders back. And I see a lot of this. So, if I have a patient who comes in and I kind of see that type of presentation, a lot of my coaching involves educating on how to do a proper chest stretch and reinforcing the fact that we need to work on our scapular stabilizers, or scapular retractors specifically, that pull the shoulder back. So it's rowing exercises, thoracic extensions, trying to squeeze the shoulder blades together, and just kind of being mindful of how to stretch, and then eliminating some of the cues that are there. So it's not just the cell phone. Laptops are terrible at causing some of this discomfort as well. And so we try to work on that as well.
Great. And how do you treat plantar fasciitis?
Gotcha. So see it a lot. It depends on the patient. Uh, Oftentimes it's a combination of proper shoes and proper sole, like insoles, and not necessarily custom soles, which usually hurt, usually a softer one. We go over appropriate stretches. Very, very, very occasionally, we will do an injection for them. You don't want to over inject a plantar fascia, because you can actually destroy the fat underneath the bottom of the foot and it can hurt more. So I always try to go in from conservative measures to aggressive measures, and we talk about that.
Great. And what can you do for severe arthritis in a hip? I'm trying to avoid surgery.
Gotcha. All right. So severe arthritis is definitely a challenging thing. And, it's one of those things where like we do have the right treatment. It is a hip replacement, but not everybody is appropriate for a hip replacement. So we have a couple of options. We try to manage the pain with medications, appropriate use of a device like a cane or a hemi walker, so that we don't have to bear weight through it. I do some hip injections. I always, tell people if it's really severe arthritis, my hip injection is more of a Band-Aid, and it's not a fix, because you can't fix the arthritis, but we can fix how we feel with it. So it is a challenging disease process for sure, but we have a couple of tools in our toolbox to try to mitigate that.
Great. This Still questions coming in. So the next one is, how does one strengthen one's glutes and hamstrings to get them in balance?
Oh man. Uh, I love bridges. I think bridges are probably one of the best exercises that we have. And for my patients who have weak glutes, we tend to do them. I do them with them. I make sure that they leave knowing how to do it. Um, Hamstrings are another tough leg, exercise to kind of train. But basically, one that I like is the patient is lying face down, and they'll curl their legs with maybe an ankle weight at the bottom of their ankle. Um, so that's one good way. We also go over things like wall squats, and then some other ones like that. But yeah.
Okay, it looks like I'm down to my last question. So if you have any other questions at home, please hurry up and send them in. And so this question is, can you treat Morton's neuroma?
Mortons Neuroma. So I have like one or two patients with Mortons Neuroma. Generally, I will try an injection. My injections are usually good. Morton's Neuroma is tricky because they come back. And so if one injection gets the job done and you don't need to hear me anymore, that's great. But if the injection doesn't work, I'm usually referring you to a podiatrist to have it taken out. It's a tough. That is a tough thing because it involves a nerve that just overgrows, and we try to calm it down with the steroid shots, but sometimes it helps, and sometimes it's just too irritated, and you're always using your foot because you always have to walk, so it never just gets 100% better. So that is also a very challenging case for sure. But absolutely, I see I have a couple of people with that, and we try with our injections first.
Okay. What do you do if you have no cartilage in your right knee? What therapies can be used instead of surgery?
Okay. So um, after the knee wears down, there's no cartilage. Depending upon the severity of the arthritis in the whole knee, we can try gel shots. There is a procedure, and I do those. There is a fairly new procedure called a genicular RFA. I don't do that procedure, but I do know colleagues who do, and I can steer you in the right direction for those procedures too. Um, of course, um, strengthening the knee is of utmost importance. It doesn't matter how well we block the knee pain or the or try to add cushioning with the gel. If we don't have a strong quadriceps, if we don't have a strong glute, that doesn't matter. So strengthening is always my number one priority in trying to help people. And then probably I would go gel shots first. And if we need to talk about alternative options, if surgery truly isn't an option for you, we will have that conversation.
Thank you. Um, I'm going to try my best to pronounce this next condition. How do you treat patients with ankylosing spondylitis?
Spondylitis. Yeah,
Yes. Have
got it.
had it for 40 years and
Mm,
seems fused, but wonder if it might get worse.
gotcha. So AS is a tough condition because basically your spine is just developing bone, and that limits your range of motion. Um, Actually focusing on, depending upon how severe the ankylosing spondylitis is, a lot of our focus is making sure that your mobility in breathing is uh, allowable. Because what happens is you kind of hunch over and then you suddenly can't have the ability to take a deep breath. So we focus on function like that. There are different pain injections that we do, or we recommend a couple of my colleagues do, depending upon the severity and the location of the spot where the spondylitis is going. There's pain medications. Manual therapy can actually be pretty helpful here. We try it. It really depends on how severe. That's not a condition where I'm cracking the back. That is more of a soft tissue technique on that spine. Every spine is different, so I always try to preface that. But for sure, we have a handful of patients with ankylosing spondylitis, and usually some combination of medications, modalities, stretching, the occasional procedure is how I manage them.
Great. It looks like that's all the questions we have. Thank you so much, Dr. Annunziato. If anyone at home is looking to perhaps seek a consultation with Dr. Annunziato, his phone number is on the page right now, as well as all the different locations that his office is located at. So thank you again, Dr. Annunziato, for your time tonight.
No problem.
And going through all those questions. There was certainly many questions. So thank you very much for your time.
Absolutely.